Hyperglycemia in critical ill patients, not DKA or HHS education, January 2025. The objectives of this model is to help the nurse understand the hyperglycemia in critical care patients that are not in DKA or HHS. Further, to help them understand the insulin drip protocol for the specific population of patients, how to initiate the order set, how to make columnar changes in CPOE, how to document insulin titration, how to manage hypoglycemic episodes, and understand the concept of transitioning from IV insulin to subcutaneous. The purpose of this educational module is to provide a high quality, standardized, and therapeutic approach in the management of patients with hyperglycemia in critical care patients who are not in DKA or HHS, but still require an insulin drip. This is a general guideline, and the staff should revise the guide as needed to meet the individual patient's needs. The protocol is applicable for adults 18 or older admitted to the intensive care unit that are not pregnant who have hyperglycemia. This guide may not be applicable to patients that are perioperative. Every patient is an individual, and the guides and the standards should be revised to meet the individual needs of a patient. Definitions. Stress hyperglycemia is defined as blood sugar glucose greater than 140 milligrams per deciliter without a previous history of diabetes or a glycated hemoglobin A1C greater than 6.5%. Diabetes in the inpatient setting is any patient with a hemoglobin A1C greater than 6.5%. And hyperglycemia in critical ill patients is defined as blood glucose greater than 200 milligrams per deciliter. Hyperglycemia in critical ill patients is an illness that leads to stress hyperglycemia, and stress hyperglycemia exacerbates the illness. Uncontrolled hyperglycemia leads to increased morbidity and the mortality in critical ill patients. The goal of this management is for patients that are critically ill who are hypoglycemic, glucose should be kept between 140 and 180 milligrams per deciliter. The procedure. The provider will assess any patient in the intensive care unit and determine if they meet the criteria for hypoglycemia in the critical ill patient. The recommended criteria for hypoglycemia in critical ill patients is a blood glucose that's greater than or equal to 300 milligrams per deciliter on admission to the ICU, or blood glucose that's greater than 200 milligrams per deciliter for more than 12 hours despite subcutaneous insulin treatment. Any patient determined as having hypoglycemia in the critical ill by the provider can be started on the insulin drip protocol. The provider will place the order for insulin drip protocol for these patients. It is recommended that all patients start on column 2 as a default. Patients can be started on column 1 if they are insulin naive and have total daily dose of insulin less than 30 units. This protocol is for critical ill patients, not DKA or HHS. If it is suspected the patient has DKA or HHS, use the appropriate protocol for hypoglycemic emergencies. Starting the insulin drip protocol. First, we will discontinue all oral or injectable diabetes medication or any previous insulin orders. Most patients will start at column 2. For patients who are insulin naive or have a total daily dose less than 30 units a day, they will start at column 1. Column 3 and 4 is started by the intensivist or the endocrinologist recommendations. We will get the patient blood glucose prior to starting the drip. Start the insulin drip at the level based on the table. For example, when starting the insulin drip, if the patient insulin is at a 250 milligrams a deciliter prior to starting the drip, they will be on column 2. Look for the insulin rate based on the glucose level. In this example, the insulin drip should be started at 4 units an hour. Glucose monitoring will occur every hour via finger stick or venous blood work. If a patient has no insulin drip changes for 4 hours, glucose would be monitored every 2 hours. If any column reassignments occur, glucose check goes back to every 1 hour. Point of care for blood glucose. Use clinical judgment to evaluate the accuracy of the point of care results in patients with conditions such as hypoxia, perfusion issues, anemia, or hypotension. If results are inconsistent with the patient's clinical condition, perform a confirmatory lab glucose test. All point of care glucose will automatically be resulted in the patient's electronic health record. If the point of care glucose needs to be invalidated, contaminated test strip, wrong patient, insufficient blood sample, and you do not wish for the results to go to the patient EHR, please check procedure error on the glucometer. Column changes. Patient must be on an insulin drip for 2 hours from start before any column changes can be made. When moving up a column, if a blood glucose is greater than or equal to 180 milligrams a DL and does not decrease by 60 milligrams a deciliter within 2 hours, if the patient is already on column 4, we're going to notify the provider. When moving down a column, if the blood glucose is less than 140 milligrams a deciliter times 2, or if the patient is already on column 1, notify the provider. Example of column changes. Moving up a column. Patient who's on column 2 at 3 units an hour. At 6 a.m., the glucose is 220 milligrams a deciliter. Insulin is changed to 4 units. At 7 a.m., the glucose is 240 milligrams a deciliter on a 4 units an hour. You can go up a column to column 3 and start the insulin at 6 units an hour. When moving down a column, patient is on column 3 at 3 units an hour. At 1400 hours, glucose is at 130 milligrams a deciliter. Insulin is changed to 1.5 units an hour. At 1500, glucose is at 120 milligrams a deciliter on 1.5 units an hour. Go down to column 2 and start the insulin at 1 unit per hour. How to order the protocol in CPOE. In the ordering tab, within a patient's chart, search for insulin drip protocol for ICU. This protocol is for patients that are not in DKA or HHS. Open the order. Column 2 is defaulted, so you may have to change to a different column if advised by the provider. Make sure you click on the hyperglycemia protocol if not already ordered. How to order column changes in CPOE. After starting the insulin drip, if a patient needs to be moved up or down a column, make sure to use the column reassignment order set to order the new column. Search for not DKA, HHS insulin column reassignment in the ordering search tab. The insulin protocol for not DKA or HHS patient only has 4 columns. Make sure to discontinue the old column prior to initiating the new column. If this is not done, this could cause confusion during change of shift with other patients. How to document insulin drip titration. All insulin drip documentation should happen in ClinDoc. Click on the ClinDoc icon to launch the documentation in PCH. In PCH, click on Add Note at the bottom of the screen. Then on the right-hand side, search under Templates for the critical care drip titration record. Double-click on the title or drag to the center screen to open the template and begin charting. In the template, you'll notice all critical drip drugs you can document on. Click to open up the documentation insulin area. Enter in the glucose level that promoted the change in the new drip rate. In the reference section, you can see the insulin column management table. Make sure to use the correct one. The documentation needs to occur whenever the insulin drip rate is changed. Hypoglycemic episodes. Follow the hypoglycemic chart in the section listed for patients on insulin drips, not DKA or HHS. For glucose less than 100 but greater than 70, whole insulin drips give half amp 12.5 milligrams D50 IV push times 1 and obtain blood glucose in 15 minutes. If repeated blood glucose is greater than 100, get a second blood glucose in 15 minutes to ensure blood glucose greater than 100 and restart your insulin drip at a lower column. If a repeated blood glucose remains less than 100 but greater than 70, give 1 amp of D50 IV push times 1. Obtain blood glucose in 15 minutes. Notify the provider. Restart insulin drip at a lower column when blood glucose is 140 milligrams a deciliter times 2 hours. For glucose that is less than or equal to 70, whole insulin drip, give 1 amp of D50 IV push times 1 and obtain the blood glucose in 15 minutes. If repeated blood glucose is greater than 100, get a second blood glucose in 15 minutes to ensure blood glucose greater than 100. Restart insulin drip at a lower column. If repeated blood glucose is less than 100 but greater than 70, give 1 amp of D50 IV push times 1 and obtain blood glucose in 15 minutes. Notify the provider. Restart insulin drip at a lower column when blood glucose is greater than 140 times 2 hours. If repeated blood glucose is less than or equal to 70, give another amp of D50 IV push times 1 and obtain the blood glucose in 15 minutes. Notify the provider. Consider adding D5.5 normal saline at 150 to 200 milliliters an hour. Restart insulin drip at a lower column when blood glucose is greater than 140 times 2 hours. Transitioning from IV insulin drip to subcutaneous insulin. The provider will determine when the patient can be taken off the insulin drip. The criteria for taking these patients off the insulin drip is subjected to the illness and will be determined by the ICU provider taking care of the patient. Once this order has been given by the provider, the following recommendations should be followed prior to turning the drip off. Blood glucose should be in goal range for 4 hours prior to discontinuation of drip. Administer sub-Q basal insulin, glargine, amount first, then wait 1 to 2 hours before discontinuing drip. The provider may use the subcutaneous to IV insulin drip order set or the hyperglycemic for non-critical ill order set to place the basal and bolus insulin order. Please make sure to discontinue any insulin drip order from the MAR once the transition has been made.